Aubrey is a clinical psychologist and assistant professor in the Department of Psychology. Her research focuses on using non-traditional service delivery models, such as primary care, behavioral health integration, telehealth, and community outreach to increase access to mental health care for underserved populations. Her talk today, which I'm really excited to hear, is on SHARE, an exposure-based psychotherapy group for incarcerated women who have experienced sexual violence victimization. So without further ado, Dr. Dueweke will give you the screen.
Great, thank you. Let me start sharing my slides. All right, can everybody see my screen? Oh, I think I just put, there we go. Just put my Zoom up there. Okay, can you see my slides?
Yes.
Great. So thank you so much for inviting me to be a part of this speaker series. I was mentioning earlier on the call that this is a part of my work that I haven't gotten to share as much with folks at ETSU. So I'm excited to have the opportunity to talk a little bit about it. A lot of this is coming from work that I did while I was a graduate student in the clinical psychology program at the University of Arkansas. And I have to also shout out my colleagues, Melissa Zielinski, Marie Carlson, and Anna Bridges, who are the main developers of this treatment group that I'm going to be talking to you about today. So I know some folks on the call may be more familiar with trauma than others, but I wanted to give a quick overview. So when we talk about trauma exposure and traumatic events, what this refers to is actual or threatened death or serious injury or actual or threatened sexual violence. And people can be exposed to trauma in a number of ways, ranging from directly experiencing the traumatic event to witnessing a traumatic event happening to somebody else, or learning about a violent or traumatic event in the context of their job. Just some examples of trauma exposures that you might commonly hear about: combat or war exposure, rape, homicide or suicide, domestic violence, natural disasters, etc. And unfortunately, trauma exposure is quite common. So the data on the screen here are showing results from the National Stressful Events Survey, which was a survey that was conducted about 10 years ago with a sample of nationally representative US adults. And you can see that about almost 90% of adults surveys endorsed experiencing at least one of the traumatic events listed in the survey. And you can see the prevalence rates for the specific trauma types in the bars to the left. So trauma exposure is pretty common. And there are a number of pathways that can happen kind of after one is exposed to trauma. So unfortunately, trauma exposure is common, but the good news is resistance or resilience is also common. So it's not uncommon for people to be exposed to a traumatic event and either never experience any major problems or experience initial symptoms in the month following exposure that then remit over time. So if you look at this graph, you can see that most people don't have long-term problems. It shows that, sorry, I should explain what the graph is showing. So the graph is showing the percent of people that have PTSD symptoms at different time points following trauma exposure. And then the different lines represent different types of trauma exposure. So you can see that after childhood trauma, non-intentional traumas like natural disasters, even in the month following exposure, the rates of PTSD symptoms that we see are around 30%. Rates of PTSD symptoms are much, much higher in the month following sexual assault, but those also tend to remit over time. So in the year following trauma exposure, we see lower rates of PTSD symptoms. But what about the people that don't experience recovery over time or resistance to initial trauma symptoms? There are definitely a group of people that do experience lasting negative changes following trauma exposure. Some of the common mental health outcomes following trauma exposure include depression, anxiety, and post-traumatic stress disorder. There are also health outcomes. People can experience physical health issues and also difficulties with intimacy and interpersonal relationships following trauma exposure, particularly when the trauma is of an interpersonal nature. So post-traumatic stress disorder, I mentioned as one of the common mental health outcomes that can develop after trauma exposure. There are 4 main symptom clusters that comprise a diagnosis of PTSD. So when one is experiencing PTSD symptoms, this often shows up in the form of re-experiencing symptoms. So these are things like nightmares, flashbacks, and having really strong physical reactions to trauma cues. Another hallmark symptom of PTSD is avoidance. So folks with PTSD tend to avoid thinking about or talking about the trauma, can resort to substance use as a coping strategy, again, to help kind of numb out and avoid trauma memories. They also will tend to avoid places and activities that remind them of the trauma. Hypervigilance is another symptom cluster. So this is when people are having difficulty concentrating, difficulty sleeping. They might have an exaggerated startle response or feel like they're constantly on guard or engage in aggressive behavior. And then finally, changes in thoughts and feelings are common. So as I mentioned, experiencing depression, anxiety, persistent negative mood, negative thinking, feelings of guilt or shame, and feeling distance from other people. So when you hear someone talk about having a diagnosis of PTSD, this is the symptom cluster. This is kind of what it tends to look like. We do have several effective treatments for PTSD. The VA has endorsed at least 2 as gold standard treatments. These are called prolonged exposure and cognitive processing therapy. Both are cognitive behavioral treatments that focus on helping the person kind of process their trauma memories in a safe way. And I'll get into more detail about what that can look like as I'm talking about the SHARE group and the components that we included. And then just, this probably doesn't need mentioning, but why there are a lot of positive implications for reducing PTSD symptoms. So when we help somebody address their PTSD symptoms, it has implications for their ability to kind of re-engage in their life, including getting an education, getting and keeping a job, getting and keeping stable housing, having healthy relationships, being able to think more clearly, provide for their family, stay sober, etc. So there are a lot of good downstream effects of providing effective treatment for people that are suffering from PTSD. So I just gave a very brief overview of trauma exposure and PTSD. And I next want to move into some discussion of why we chose to focus on incarcerated women as the target population for this treatment. So part of the answer to that question involves knowing a little bit about history and what is going on with the US carceral system. So today, the United States incarcerates more of its citizens than any other country in the world. You can see, looking at these graphs, rates of incarceration over the last 40 years. And most of those graphs look pretty stable, but the United States graph, you can see that rates of incarceration have just continued to rise over the last several decades. So today, there are more than 1.2 million people in prisons and approximately 750,000 people in jails in the United States. A lot of people behind bars in our country. And I'll also note that the data that I'm going to be sharing today and where we started this group was in Arkansas And then we eventually also expanded to offer this group at some facilities in Kentucky and Washington. So I just wanted to highlight that where we were doing this work, we were in the states with the highest rates of incarceration. So it was particularly relevant to being in that part of the country. And then what about women specifically? So this pattern definitely holds true for women. And in fact, over the last couple of decades, the number of incarcerated women has been growing at twice the rate of men. So it's definitely relevant to women as well. And there are a lot of women behind bars. And again, I'll highlight that in Kentucky and Arkansas, where the group was initially developed, was the state with the 8th highest number of incarcerated women, and Kentucky was the 2nd highest number of incarcerated women. Yeah. So, and we can see Tennessee's up there as well, just below Arkansas. Here it is. I don't know if you can see my cursor, but so that would make Tennessee, I guess, the 10th or 11th highest rate in the country. And there is a very clear support in the literature for trauma as a risk factor and part of the pathway that puts women at risk for becoming incarcerated. So I wanted to highlight 2 things. First, we know that exposure to childhood trauma and adversity is a risk factor for repeated victimization in adulthood. So experiencing childhood trauma is a risk factor for experiencing adult trauma. And then also the relationship between childhood trauma and adversity and the relationship between the relationships between childhood trauma and adult trauma and number of convictions are mediated by lifetime mental health and substance use disorders. So this is providing support for the narrative that women who are exposed to trauma during childhood are often also likely being exposed to trauma during adulthood. It's not uncommon for those women to develop mental health struggles and substance use disorders, which puts them greatly at risk for becoming incarcerated. So this is a particularly high-risk population. My colleagues a couple of years ago put out a literature review just looking at studies of mental illness and trauma exposure among incarcerated women, and found that the rates of sexual violence victimization are incredibly high among incarcerated women. With, sorry, I wanted to share some of their graphs. So looking at all of these studies put together, if they focused on the studies that used a validated measure of sexual assault, they found that between 50 and 66% of incarcerated women have experienced child sexual assault, and between 56 and 82% have experienced lifetime sexual assault. And I also want to note that knowing what we know about all the barriers to reporting or endorsing sexual assault, it's likely that these rates are perhaps even higher among incarcerated women. So very, very, very common for these women to have a history of sexual violence victimization. And I also wanted to just compare, thinking about what we know of rates among community women. We're seeing rates that are nearly twice as high among incarcerated populations. This is also from their review. So if we look at prevalence of current mental illness diagnoses, just to orient you to these graphs, the colorful lines are among study samples of incarcerated women. The Black lines are from the National Comorbidity Survey, so a sample of community women. And across the board, you can see higher rates of all of these diagnoses. So higher, nearly twice the rates of bipolar and major depressive disorder, even higher rates of PTSD. Gosh, when we're looking at substance use disorder, it's like 5 times as common among incarcerated women. And then AUD stands for alcohol use disorder, and DUD is referring to drug use disorder. So substance use and mental illness rates are much higher among incarcerated women as well. And finally, thinking about this, I guess, from a criminal justice lens as well, PTSD, treating PTSD and substance use disorders has implications for recidivism. So these graphs show that among people who have neither PTSD nor substance use disorder, and when we're comparing them to people who have a substance use diagnosis, a PTSD diagnosis, or comorbid substance use and PTSD, there are greater odds of being arrested again after release compared to people that do not have either of those diagnoses. And that pattern holds for both when we're looking at any charges as well as felony charges. So just to summarize, in the general population, trauma is highly prevalent, but particularly so among incarcerated women, it's much more prevalent, and in particular, sexual violence victimization is very, very, very common among this population, as are trauma-related disorders, PTSD, and substance use disorder. And not only are we seeing these things while people are actively incarcerated, but it also puts them at risk for being incarcerated again in the future. So hopefully in the last 15 minutes, I've convinced you of the great need for trauma-focused therapy for incarcerated women. And I want to move into telling you a little bit about this treatment group that we developed, again, when I was a graduate student in Arkansas. The whole name is kind of long. It stands for Survivors Healing from Abuse, Recovery Through Exposure. So we call it SHARE Group. It started, I believe, in January in 2012. So it predated my time in grad school by a little bit. It was first implemented in the Northwest Arkansas Community Correction Center, which is a minimum security facility and it's a women's prison. So most of the women there were incarcerated for nonviolent felonies, things like selling or using illegal drugs or financial crimes. Since its inception in 2012, we've run over 40 groups and had over 250 treatment completers. And actually those numbers are probably outdated because the group has still been going. So I want to say even more than that. To give you an idea of the basics of what this group looked like, this was an 8-session group therapy where each session lasted about 90 minutes. The group sizes ranged from 2 women to 10, kind of depended on the time of year and how many people chose to enroll at that particular time, but it was a continuously offered group. It was also a closed group. So what that means is women were not able to join part of the way through. Like if they were interested, they would kind of be put on a wait list for the next group starting up. And that makes a lot of sense if you think about the content that we were covering and issues around confidentiality, which are, bear considering in group treatment no matter what. And in particular, when we're focusing on such a sensitive topic, I think part of why this group worked was that they had some assurance of privacy and confidentiality, and women, I don't think, would have felt as safe with participants being able to come and go and only participate halfway. So I want to give an overview of what we spent those 8 sessions doing. The first session was focused on talking about group norms and confidentiality, as I was just alluding to. So guiding the group members through a conversation about what kinds of rules they wanted to set for how their group was going to go in terms of expectations around how people would be treated, and expectations around privacy and sharing or not sharing information that they heard in the group once they're outside of group and just in the facility going about their day-to-day lives. We also provided a lot of psychoeducation, some of the content that I just provided to you today in the talk. So giving them information about trauma exposure and some of the normal downstream effects of that, normalizing and giving information about the prevalence of violence victimization, and kind of talking to them about how PTSD develops and is maintained through a cycle of avoidance. And that a lot of session 2 was focused on that, kind of moving more specifically into talking about treatment rationale. Why are we asking you to come to this group and talk about one of the worst things that's ever happened to you? Why would we ask you to share that? So getting a lot of buy-in around the evidence base around imaginal exposure and why it's thought to work. And a lot of times this conversation centered on, discussing the short-term benefits of avoidance that maybe have long-term consequences that are quite harmful over time. And a lot of the women had a really clear example of that, of saying like, yeah, for example, I use substances to try to numb out and not think about what happened to me. In the short term, that worked. In the long term, it landed me here. And so I can recognize that that's not a good long-term coping strategy. And then in sessions 3 through 7, we focused on conducting imaginal exposures, which I will explain a little bit more in the next slide. But basically, imaginal exposures ask participants to describe and narrate in great detail their traumatic experience and talk about what was going on for them internally, what they were thinking and feeling, and processing that event in a therapeutic context. Because this was a group treatment, the way that this ended up looking in practice was that each of sessions 3 through 7, one woman would be kind of the identified sharer for that day. In larger groups, sometimes 2 women shared in the course of one group, but never more than 2. So one person would kind of like have the floor to be guided through this therapeutic exercise while the rest of the women listened and then provided supportive feedback at the end. And then the last group was focused on consolidating gains, talking about lessons learned and talking about relapse prevention in a way, like planning for continued healing, how they're going to continue to apply the lessons learned from group moving forward. So I mentioned earlier in this talk that there are a couple of gold standard treatments for PTSD called prolonged exposure and cognitive processing therapy. And both of those treatments are thought to work to varying degrees as a result of exposure. This idea of asking people to, again, to go into some detail about what happened to them. And I want to spend a little bit of time talking about why that works and why we chose to do that here, because I think, especially to a lay audience, that can sound pretty counterintuitive and potentially harmful. Like, why would we ask somebody, and particularly somebody who's in this very vulnerable situation where they're incarcerated, they don't have a lot of control over, their day-to-day activities. Why would you ask them in this context to tell you about their sexual violence victimization? So I want to address that can seem counterintuitive and also provide some of the rationale and evidence to support the use of imaginal exposure. So I mentioned that PTSD is thought to be maintained by avoidance, in that following trauma exposure, someone really tries to block out those memories, move on, stuff it deep down and try not to think about it ever again. But what can happen is they experience these situations where trauma memories and reminders come up and kind of bubble up unexpectedly, and when they're not wanted to, in part because the person isn't allowing themselves to process the impact of that experience. So imaginal exposure, well, let me back up. I want to explain a little bit about what this looked like in the context of SHARE, and then talk about why it's thought to work. So during these exposures where there was one identified sharer, the sharing participant is asked to briefly describe what her life was like just prior to the trauma, then move into narrating the trauma memory, starting at the beginning and kind of moving through in chronological order. And consistent with the recommendations of Edna Foa, who's the developer of prolonged exposure therapy, we encourage those participants to describe the events in detail, really connecting with all 5 senses. The therapists, and I guess I forgot to mention this, each group is led by 2 therapists that are kind of moderating. So during the imaginal exposures, the therapists provide gentle probes and questions to help participants elaborate on certain details, as well as describe physical reactions they were having, emotions and thoughts that were occurring at the time the event was happening. And then after guiding participants through that initial narration, we would address what we call hotspots, which are moments of more intense distress in the memory through either additional exposure or some Socratic dialogue where we would challenge some of those unresolved trauma thoughts. For example, thoughts around self-blame. We would try to therapeutically push back on that and kind of challenge, like, where is that coming from? And help guide the participants to a more forgiving of themselves and adaptive interpretation of what they did in that situation and why they maybe reacted the way they did. So each of these imaginal exposures took around 30 minutes, during which time the other group members are listening. At the end, if the sharing participant wanted to, they could invite the other women in the group to give feedback. Although we were careful to, we did not allow advice giving. So we did not allow other group members to say, well, you should have done this or that in this situation. The feedback that was invited and solicited was supposed to be supportive in nature. And then we provided kind of a therapeutic summary, extraction of salient themes and suggestions about future growth in terms of how the trauma impacted them and how, knowing that, they could kind of move forward in interpersonal relationships post incarceration. So imaginal exposure is thought to work as a result of habituation and new learning. So part of that experience is breaking the cycle of avoidance, right? So oftentimes these women had been avoiding thinking about or talking about these events for years and years and years. And in avoiding for so long, they're kind of reinforcing that idea to themselves of like, this is a really dangerous memory, and I would completely fall apart if I, even thought about addressing this or thinking, allowing myself to think about it, which oftentimes is not really true. So in doing these exposures, they break that cycle of avoidance. They learn that the trauma memories themselves are not dangerous. So while what happened to them, yes, was very dangerous, the memory and engaging in thoughts about the memory are not inherently a dangerous situation. They also often learn that they have better control, I want to say, over their emotions than they thought. And a lot of times people think, if I dip my toe in and start to engage in this memory, I'm going to totally lose control. I'm going to go crazy. I'll never be able to stop crying. And they learn, of course, that that's not true, but rather that emotions, can feel intense and then subside over time. We also talk to them about the idea of trauma processing. We use a metaphor. I call it the file drawer, or the clothes dresser drawer metaphor. And saying, look, when you're exposed to this traumatic experience, your brain is really grabbing all of those details of that experience and shoving them in to try to be like, wow, I need to make sure that I, get a solid understanding of all of this stuff so that this never happens again. But then it's like as if you threw all of your clothes in your drawer without folding them up, and you just try to close the door and stuff it in, be like, okay, it's all in. I've got it. I'm not dealing with that anymore. But what happens when you do that, clothes can kind of fall out, or the door might open on you when you don't want it to. And so we're allowing them to kind of take each, working in the metaphor, take each item of clothing out, look at it, process it in a safe space, fold it up and put it away the right way. So that is the thinking behind why we do these imaginal exposures. I feel like I didn't explain that the best. I hope I explained it okay. I'm seeing a couple of thumbs up, so I'll keep going. The next rationale that I wanted to address is why do this in a group instead of one-on-one? And there's a couple reasons for that. One is if we think about a population health perspective, in terms of the way we think about the impact of interventions, we could have the most efficacious intervention in the world that really, really helps, the person that gets it a lot. But if you only are able to get that intervention to a couple of people, then globally the impact of that is not very large. And so whenever I'm thinking, and this is definitely my bias and my lens in the way that I think about interventions, is I want them to be able to reach the most amount of people possible, and in particular in these settings where there is such a great need. So I'll remind you of that need. In women's correctional facilities, the vast majority of residents have experienced sexual violence victimization. And we know that compared to other trauma types, natural recovery is less common with sexual violence, and in particular with repeated sexual violence victimization. So it's reasonable to expect that a lot of these women have PTSD and lingering impact of trauma exposure. And just to kind of give an example and math it out for you in terms of that equation about reach, one of the gold standard treatments that I mentioned is called cognitive processing therapy, or CPT. The typical modality in which that's delivered is individual format. So one therapist, one client, meeting weekly for up to 12 weeks. If we do the math, the total therapy time per client per therapist is between 12 and 18 hours to get that person through the course of treatment. In contrast, SHARE, it has 2 therapists that are managing the group. Around 8 clients was kind of the mode number of group participants that we saw, meeting for 90 minutes a week for 8 weeks. If you do all the math, that equates to about 3 hours of therapist time per client that's being reached. So in the long term, SHARE is capable of reaching 4 to 6 times more people than an individual trauma-focused treatment. I'm going to move into sharing some of our outcomes research showing the effectiveness of this intervention, but I wanted to also mention participants could self-select into this group, and we were not there were not diagnostic requirements. We weren't trying to do a lot of digging to see if they were really well suited for the group or whatever. If participants endorsed having experienced sexual violence and said that they were still experiencing problems as a result, they could enroll in the group. The one requirement that we did try to stick to was we wanted to make sure that women were in the facility long enough to complete the full course of treatment. So we did not allow women to start the group if they were about to be released in the next couple of weeks. That said, we did not have requirements about how long they needed to be in the facility before starting treatment. And part of that comes from, we did a study where we looked to see if treatment efficacy differed based on length of incarceration, and we saw no differences. So we had some participants that would enroll in this group right away, as soon as they were admitted to the facility, and then we had other people that had been in the facility for a year or 2 before deciding to engage in this treatment, and both of those people benefited equally. So again, probably this is a little outdated by now, but on average, the age of our participants was about 33. The vast majority of the participants were mothers. So thinking about intergenerational transmission of trauma and thinking about this from a prevention lens, also very good to be intervening and dealing with trauma impacts now, so that, you know, in the hope that these women could be better equipped to be more engaged mothers and protect their child from maybe similar victimization. Most of the women were white. That's reflective of the demographics of Northwest Arkansas. And then looking at the sexual trauma history, over 80% experienced sexual assault by a family member, acquaintance, over 50% experienced sexual assault by a stranger, and close to 75% endorsed experiencing child sexual abuse. So in the remaining time, I wanted to share some of the outcomes research because it's really exciting. To date, we have done several different kinds of studies now. So started with open enrollment, initial pilot studies. Then we, like I said, one of the treatment developers got a job at Murray State in Kentucky. And so she took the group with her and got connected with a facility there and started implementing it in Kentucky. So we also had the opportunity to do kind of a generalizability study to see, you know, is there just like something magical happening at this one facility, or is this something we can translate to other locations? We've also done a follow-up study, so looking at whether treatment outcomes are maintained over time. And we're in the process of working on looking at what happens post-release with some of these women. Also recently did a feasibility and acceptability study. So I guess I didn't mention too much, but we had in different conference, you know, presentations and situations have had the experience of having people push back a little bit and be like, wow, I really don't think this is a good idea. I think you are potentially like putting these women in harm's way. We've, you know, empirically tested that and haven't found that to be true. And in fact, I'm excited to share some participant quotes about some of the unique benefits actually of doing this type of treatment in a group setting. We've also looked at the timing study I mentioned on the last slide in terms of timing of how long they've been incarcerated. I led a paper looking at whether the size of the group impacted effectiveness. So are bigger or smaller groups better, and didn't find any significant differences. And then moving forward, we're interested in looking at some of the mechanisms that are driving the effectiveness. But I don't have time to share all of that today. I will briefly share some of the findings on pre-post treatment change. So I'll just skip ahead to the outcome slide. We see significant reductions in PTSD from pre to post treatment. The bar graph on the left is showing the Arkansas groups. The bar graph on the right is showing some of the Kentucky groups, with a pretty reductions with a large effect size. This is also just putting into context the measure that we used to score and assess for PTSD symptoms is called the PCL-5. On that measure, a score of between 31 and 35 is indicative, 31 and 33 is indicative of a probable PTSD diagnosis. So you can see most of the women were at or above that cutoff at pre-treatment and far below that cutoff at post-treatment. Similar pattern for depressive symptoms. Again, just giving some of the benchmarks of how these scores are interpreted. This was the PHQ-9. And I won't spend too much time on that. I think the story is pretty straightforward. I also wanted to share some follow-up data. So looking at how these women were doing 3 months after completing the treatment. So the data that I'm about to present are from 45 participants that had data at all 3 time points, including pre and post treatment, as well as the follow-up time point. And you can see that the reductions in PTSD symptom severity were maintained over time, with actually participants reporting even lower symptoms at follow-up. And Similar pattern for depressive symptoms. This is just, I guess, presenting the same data in a different way. This is showing the percentage of participants that were at or above the clinical cutoff on the PCL, which is the measure of PTSD, and the PHQ-9, which is the measure of depression, at pre, post, and follow-up. And then moving into some of the results about acceptability of the intervention, when we asked, and this was in the post-treatment packet, asked women, would you recommend this group to other women? The vast majority said yes, they would. And then we had some open-ended questions where we asked women to write about what impact the group had on them. And what they wrote were all variations on, it was really helpful. It helped me feel kind of free that I can, continue with, that I can live my life now and not be so burdened by these symptoms. I'll share some specific quotes. Most of them centered around emotional release in terms of feeling like a weight was lifted from their shoulders, feeling like they were able to finally let go of all the pain and anger that they'd been holding. One person wrote, I've slept better in the last month and a half than I have in 25 years. I've got a new piece about me and my life. And then a really, really cool finding, because I think I mentioned there was some skepticism about whether, it was a good thing to be doing this intense trauma exposure treatment in a group setting. So we also asked, what impact did listening to others' stories have? Because that's really one of the unique ingredients, right? Is when you're in individual treatment, it's just you working with your therapist. In a group treatment, you have the opportunity to listen to all these other women that have been through a similar experience. And by and large, the most common takeaway was, I felt like I realized I'm not alone, which is hugely powerful when we think about some of the guilt and shame that is typical for people to carry following sexual violence victimization. Being able to realize there are lots of other people who have been through similar situations. You're not alone in what happened to you. You're not alone in your feelings, and it's okay to share. And your story matters was really, really impactful for our group participants. I do want to have time for questions, so I'll end it there. I want to acknowledge, like I said, Anna Bridges, Melissa Zielinski, and Marie Carlson, who are really the driving developers of this group. Really exciting. We are actually there currently working on getting a treatment manual for this group published and disseminating it more widely than just in Arkansas and Kentucky. They've been doing trainings for providers in Washington State, and I would love to one day be able to offer that in facilities here in Northeast Tennessee. So we'll see, maybe in the next couple of years can look at getting this group translated and implemented here. Wanted to acknowledge some of the funding sources that have supported this work. And I will stop there for some questions. Let me see if I can stop sharing my screen so I can see all your faces again. There we go.
Thank you, Dr. Dueweke. That was fascinating, and we appreciate your taking time out to give us this report on research. So surely there are some questions, and we did record this session, so it will be on our website for those who couldn't sign in today.
I have a question.
Yes.
I don't know if you know me well enough to know that part of my day job is just being skeptical and science.
Everybody knows that.
And one of the things that's happened for a long time is EMDR has become really popular. And for those who know, it's eye movement desensitization and reprogramming. And Scott Lilienfeld, who was like me, but in the clinical realm at Emory, used to publish papers about how EMDR works, but it doesn't work because of any eye movement. It works because of immersion and exposure.
Mm-hmm.
And I imagine it's similar. I don't know, I'm not a trained therapist, but I imagine it's similar to your imagery exposure, imaginal exposure. And I wonder, but the thing is, like you were talking about wanting to reach the most amount of people. And the problem with EMDR is, number one, it's not clear that it works any better than just mere exposure. And I want to know your opinions on that. And two, it's highly controlled and gateway and paywalled, and it's like the secret society. You have to go through all this training before you can even use it, which really limits its access. And then Francine Shapiro, I guess, is making a ton of money because of her regulation of this EMDR. I wonder if you could talk a little bit about EMDR and sort of regular exposure without the eye movements, and the validity of EMDR relative to regular imaginal exposure.
Yes, I tend to agree with you and Scott Lilienfeld that the efficacy of EMDR is driven by exposure, which is the evidence-based ingredient that's part of that, rather than like because you're moving your eyes back and forth. Some people might disagree with me, and I guess I'm on record now saying that, but that is my view as well. And so there was nothing like EMDR happening in this group. When I talk about imaginal exposure, that is just kind of like the typical baseline level of exposure, which is having the person recount their experience in great detail. In terms of accessibility of treatments, I tend to agree with you on that as well, of like, and I think this is a good example of that, of like people who are familiar, I guess, Julia, you probably are familiar with both CPT and PE, and you can certainly recognize some of those components being applied in this group. I think it speaks to the importance of having good training and understanding the why behind why this element of the treatment works, and be able to apply it flexibly in different settings, whether or not you have a specific session by session manual that you've been trained and blessed to do. Does that answer kind of your question and thought process, Wally? I'm trying to think if you asked something else.
No, that's fine. What I'm worried about is, well, accessibility. And then I guess I'm worried about selling a product that doesn't do what it says it do, or does more than, I'm not sure how to, it's like you're buying extra when you buy it. And I've always been curious about it, because it seems to me that there ought to be truth in advertising, and if the effectiveness of EMDR is really based on the exposure, not the eye movements, then I feel like, as a psychologist who should be scientifically focused and skeptical, then that is being disingenuous. And I know that people love it, EMDR, and they swear by it, and they make their money off of it and all that. But I'm just, I like to think about the mechanisms that underwrite effectiveness or causal effects. And if it's not what it's sold as, it just doesn't seem ethical, maybe. But I'm not calling you. I also want to be clear. I'm not saying people are unethical.
We did not do EMDR in this group.
Yeah. But I'm just curious about the underwriting mechanisms.
Yeah, and the ethics of, like, if you package those mechanisms a little bit different and say, like, I invented this thing, now pay me money for it, then that maybe isn't the best. Yes. Hey,
Aubrey, I have a question. I was really delighted to see the slides where the rate of depression went down over time, both post and then in the follow-ups, and that the measure was PHQ-9 is the way. So I'm wondering if you know the role of listening to symptoms of depressions or feelings of depression subsiding post treatment as well as over time, and what the role of listening was, what kind of instructions you gave about listening. And you did say no advice giving, but so I'm just wondering what kind of instructions and what you feel like the role of listening was.
Yes, and this is, I wish I had data to show, because I mentioned one of the things we're looking at is mechanisms. And we actually had a grant. I would expect a paper coming out on this very soon, but we had a grant where we actually, for a time, were able to randomize people who agreed to being randomized to a listening only group. And the way that we did that was we had past leaders of the group actually record audio scripts that were amalgamations of stories that we've heard over the course of doing this group, and actually ran several groups where there were women who just listened to those recordings that were set up to sound exactly like somebody going through an imaginal exposure. And I think that the way that we didn't force that on anyone. So anyone that like really was ready to share their story would be in the exposure group. People that were less ready or said, well, I don't really mind to be randomized, had the option of being randomized to the listening only group, specifically to address that question that you just asked of like, to what degree is the effectiveness of this group driven by sharing your own story in a therapeutic environment versus also being in an environment where you're hearing kind of that like, I'm not alone piece. I wish I haven't seen the data, so I'm not gonna go out on a limb to like speak to which one was better. But email me in a year and ask, and I'll be able to speak to that question.
I will put it on my calendar and email that. Keep going.
Anecdotally, I think that's part of it for sure. It seemed to be so, and I can email this group. I would love to have you guys, if you're interested, read the paper that had a lot more of the rich data about participant quotes, the like, I'm not alone, my story matters sentiment, I think is a strong contributor to symptom improvements in this group, as well as like the typical gold standard exposure mechanisms.
I have a question. This isn't about your research. It's just I'm just curious. Why do you think the rates of incarceration for women in Kentucky and Arkansas and even Tennessee are so high?
I would expect part of that is the pathway that I mentioned in terms of substance use as a coping mechanism and common response to trauma exposure. I think it's a little bit out of my area, but I would assume that rates of substance use in those particular states are higher if we think about all the risk factors and socioeconomic status of women in those states. That's going to be my guess.
Right.
Yes.
Yeah, I think just to piggyback off of that, do you think rurality, sorry, I always have a hard time saying that word, contributes to that at all?
I think maybe, yeah. I think that would be an interesting question. And we actually haven't, I know less about the implementation that's been happening in Washington State. I don't know as much about if that's in a rural setting or not, but thinking about, the parts of Arkansas and Kentucky that were kind of like the catchment area that women were coming from to be housed in these facilities, I think were more rural. So that could be part of it for sure.
And
Well,
there's no reason to.
Go ahead, Wally.
I was just going to say, there's no reason to think that the therapy would be unique to women. It probably applies to everybody, I would assume.
I think so. I've thought about that a lot because running these groups felt so special. It felt like there was some like secret sauce happening that like all of the women that participated, they loved it, they got so much better. And I've thought like, man, there should be more, someone should be doing more look into like the group factors that kind of maybe have unique curative influence on PTSD. And I'm less familiar with the VA. I think that there are some my understanding is that most of the treatment groups that exist are not exposure based. because people tend to have concerns about like re-victimization and having negative impact of hearing other people recount their trauma memories. But I wonder if to me, that's a very interesting future direction to explore. Like, what would this look like in a group of men that have combat exposure, for example? I think maybe the shared trauma type is a part of it. Like, I don't know if it would be as helpful to have a group with several different kinds of trauma exposures. And I also don't think it would be good to have a mixed gender group. But those are just my personal thoughts. I haven't seen research to back those up.
I was a part of a cognitive processing therapy group at the VA that was for women specifically who had all experienced military sexual trauma. So to kind of Aubrey's points, it was not mixed gender, it was all female identifying, and it was a unitary trauma type, although as you might expect, a lot of women in that group had multiple histories of multiple types of trauma, not just their military sexual trauma. And it was really powerful, impactful. The women did not have to share details about their kind of what we call index trauma in the group. Some chose to, some didn't. It was much more on like talking about their thoughts and feelings that resulted, that came up for them as a result of their trauma rather than dealing with the trauma. They did have to write about the trauma, but that was outside of group. I know, and as Aubrey knows too, PE groups do exist, but I've never been a part of one. But I think they happen in the VA sometimes, and I guess it depends on whether those are, I'm not sure if they're mixed gender or single trauma type or how that happens, but.
Yeah, I'm aware of, to your point, Julia, thinking about child trauma treatments. I had a lot of experience delivering trauma-focused CBT, which is like a child-focused trauma treatment when I was at MUSC, and was aware of some group iterations of that. But the way that they did it was that the trauma, like the imaginal exposure piece, happened in an individual session, and then the group was devoted more to just like processing themes, as you mentioned. So I don't know how the PE groups end up looking.
Well, Aubrey, I feel like you've just like rekindled feelings about why I love group work. I loved your description about like how it felt so special being there. And I've been in groups that have that same kind of feel. And was really loved listening to your presentation of this. Thank you so much for all this.
Thank you.
All right. Again, thank you so much, Aubrey. We really appreciate it.